Thanks, Caitlin, and I hope that a week from now I get introduced as Dr. Ann Pederson, because next Monday morning I'm defending my dissertation. Thank you so much. Caitlin's actually told you everything you need to know about what I'm here to share with regard to a project that BC Women's was fortunate to conduct in 2013-14 with the support of the Ministry of Health, who actually had funding from the Ministry of Jobs, Tourism and Skills Training. It was during that transition within the settlement sector that funds were available to support work. And we were specifically invited to conduct a study related to newcomer women, because as Caitlin said, I worked for the BC Centre of Excellence for Women's Health, and now I'm the Director of Population Health Promotion at BC Women's Hospital and Health Centre. So what I'm going to do this morning is describe very briefly the project and the findings of it in order to get to what I think is the exciting part, which is what we've done as a result of it. So it's no news to anyone in this room or online that women come to British Columbia from all over the world. Data from, for example, 2001-2013 indicate that more than 430,000 immigrants came to the province, half of whom were women. As a group, these women tend, on average, to be younger than their Canadian counterparts, many of whom have tremendously high levels of education, but of course, migrants to British Columbia come from all walks of life with all kinds of experiences. The project that I mentioned, and I'm going to focus on this morning, was sponsored with an interministerial memorandum of understanding. It was a partnership between the Centre of Excellence and BC Women's Hospital, but it involved literally dozens of other people, including an advisory group that was made up of representatives from the settlement sector, some of whom are represented here today, and the health sector. Because as the title said, our goal was to explore the possibilities for bridging settlement and health. The goals of the project were specifically to identify the health needs of newcomer immigrant women and to generate ideas for how settlement services and how health services and the settlement services could better align to support newcomer immigrant women's health needs and their settlement experiences. Because as Caitlin said, we understand settlement as a process. And we took from the outset a perspective that migration is a journey, not an event. And therefore, there is a process that happens, and it's our role, all of us assembled today, to look at how we can be facilitating and enhancing the health and well-being of settlers. An important perspective was that we understand that health is affected by settlement, and settlement in turn influences health. So it's that reciprocal relationship that is the core of our work. And as we know, some migrants come to the province with all the resources in the world to have a successful experience, but many come with important stories, challenges, and needs that the sector that you work in helps support and enhance. So I'm going to briefly describe the project, and then I'm going to talk about the fun things we've done since, which I hope are contributing to enhancing our capacity to improve, in this case, women's lives. As I failed to mention, that BC Women's is the only dedicated health agency in the province with a mandate to support women, newborns, and families. And that puts us in a unique position to provide support. So the project started, as many do, with a literature review. This covered both the grey and academic literature. I won't go into any details about how we searched or found things. I just want to tell you a little bit about what we learned. What we found, and it disturbed us and frustrated us because our goal was to find solutions, that literature focused on problems. It focused on documenting what didn't work and what was happening for women, but it didn't tell us what might help. And in many cases, the literature focused on very specific population groups. So again, since our mandate was to look across the spectrum of newcomer women, being only able to look at the narrow experiences, although in depth, of a particular subgroup of women made it difficult to generalize. From that literature, we did get a couple of key recommendations, and one was to develop a glossary of common healthcare terms, something we have not yet done, and to ensure the availability of interpreter services, which, as we all know, varies in terms of what's possible here in British Columbia. While we were doing the literature review, we also had somebody doing an environmental scan. This was an online search of settlement organizations, but particularly health organizations, and in particular in BC, that meant our health authorities, looking for resources that were dedicated to newcomer women. What we found, no surprise to anyone here, is that while there are lots of services available, they're not dedicated to newcomer women. And although there were a plethora of sources, they weren't necessarily cross-referenced as up to date, etc. So the health authorities and ourselves could do some work about getting those services and keeping those references up to date. Then we did a set of key informant interviews with leaders and colleagues in the health sector and the settlement sector. These were done over the phone or in person. They took about an hour. They were conducted by one of my colleagues, Alexis Boyle, who has expertise in qualitative research and herself is a migrant. And then she analyzed the findings. And what she found was that the main barriers that this group of people were saying were barriers to health care were language difficulties and cultural differences. What the cultural differences meant in terms of understanding how to make a doctor's appointment or explaining one's health issues to physicians and other health providers. Their specific recommendations were that we create a system of health navigators for women, especially women with low literacy skills. We explain how to make an appointment. We explain about translation. A second recommendation was to bring health out to communities rather than expecting people, women, to find us. And a third was to create a system of cultural brokers to explain the health system upon arrival and orient women to health services. But the highlight of our experience, of course, was focus groups with newcomer women themselves. We did 5 focus groups. We did them in the Lower Mainland here in British Columbia just because of our resource limitations. We did them in English, Farsi, Mandarin, and Punjabi with the help of translators and experienced facilitators. And all the results were recorded and then translated, recorded in their original language, translated into English, and analyzed. These were exciting interviews. The women participated ranged from having been in Canada as little as 2 weeks to having been here up to 5 years, because our definition of newcomers following the Government of Canada was 5 years or less in Canada. What we learned from those interviews, and of course there's masses of data which I'm not sharing with you, but among the things we learned were that there were barriers to accessing care, such as no understanding of the processes and procedures about how the Canadian healthcare system works. Women were perplexed by how to access services, what was the etiquette or practices for going to the hospital, particularly using emergency. There was confusion about the fees associated with premiums for MSP and premiums for cancellations, or the costs of some ambulance fees, prescription medication, eye exams, all the costs when there is a public perception that healthcare in Canada is free. There was also concern, as we heard earlier, about the difficulties of completing paperwork in English and the cultural differences between oneself and healthcare providers. So in short, we discovered that there were gaps between what the research said and the services that were available. We concluded that if we took our a broad lens, that there was a lack of gender-sensitive, women-specific, culturally competent, and evaluated services and interventions. There was certainly a lack of clarity of the resources available, and certainly a lack of coordination between settlement and health about what was available, and lots of concern and confusion about how to access services for translation. So, what did we recommend? So, I must remind you, this was a project that was 14 months long with an incredibly demanding schedule. We were required under the terms of the agreement to take some form of action. So my recommendations, the team's recommendations, are very much influenced by the time frame and the possibility, because there's far more that needs to be done. But the first one that we came up with was creating, on the basis again of literature that supported this, creating new, for newcomer women themselves, downloadable instructional videos about how the healthcare system works. But Because health literacy is not just the responsibility of individual women, but is in fact about the health system's response to newcomer women, we also had recommendations about online competency, cultural competency training and support for healthcare providers. So very briefly, the first thing we did was create resources to support newcomer women. These were created as videos, and then after we did a test at the AMSA Diversity Health Fair, people told us that they'd also like a written version of them. So we adapted the videos and made handouts. The videos and the handouts are available in 6 languages: English, French, Farsi, Punjabi, Korean, and I'm missing one, Mandarin. And the year after that, because we were developing new services at BC Women's, we created a third fact sheet about newcomer women, about explaining what nurse practitioners are and their important role in British Columbia. And this was really well timed because of the developments that I'm going to explain in a second about BC Women's. So all of these fact sheets are in the process of being translated into Arabic right now to meet the contemporary situation that we all find ourselves in. We aren't yet doing the voiceover for the videos, but hopefully we'll find some resources to do that too. As Caitlin already mentioned, BC Women's offers a system of healthcare services for newcomer women. In fact, a couple of our providers are here this morning, I'm pleased to see. These are 2 services. One's referred to as the Newcomer Women's Clinic, and the other one is called the New Beginnings Clinic. New Beginnings is specifically a service for pregnant women who find themselves in need of care, do not have a primary care provider, and don't have health insurance. And the Newcomer Clinic is provided by Nurse Practitioner Services, and it looks at everything from prevention through acute illness to referrals to specialists, with a particular focus on reproductive health care. As I was saying about our definition of newcomer women, these services are available for adults 18 and over. No geographic limitation on who's eligible to use our services. The goal is, of course, to support women now, but to help them transition into healthcare services within a couple of years. So now, I know you were told to turn off your phones, but that was just the ringer. If you'd like to grab your phone or your tablet and put in this URL, culturallyconnected.ca, this is the play along part of the talk, because this is the last thing we've developed, and we just launched in the fall. This is the tool that we built with the support of BC Children's Hospital and BC Mental Health Services Health Literacy Team, which is a resource to support healthcare providers in terms of supporting their capacity to work with culturally and linguistically diverse patients and families. I don't have time to give you an exhaustive orientation to this, but that's what you can do online. This was built as a mobile-first application. It's intended to be available without having to have a computer in your hands or in your office. And it's done in such a way that it can just be a support. It's not a comprehensive training program in cultural competency, but it is a handy-dandy tool. In Culturally Connected, we took a position which was that the most appropriate stance to support cultural competency for healthcare providers was actually to take a cultural humility approach. We embraced a definition of culture as a system of shared meanings. We recognize that for healthcare providers, being culturally competent recognizes and addresses imbalances in power, which may arise due to differences in experience, language, healthcare knowledge, and the capacity and access to resources such as information, time, and funding. And this tool, as I said, employs a cultural humility approach. We took this approach because it's the most flexible, most sincere way to address a situation in which one does not become an expert on individual cultural practices, but rather takes a stance to be open to the experiences of the person with whom you're engaging. Basic tenets include kindness, civility, respect. To adopt a stance of cultural humility, you have to be willing to commit to a system of lifelong learning, to be open to self-reflection on your own assumptions and practices, to be comfortable, frankly, with not knowing, which for healthcare providers can be a challenge. and to recognize that there is this potential for imbalance between yourself and your clients. But in so doing, by taking a stance of asking questions and being willing to be open to what you learn, as opposed to making assumptions on the basis of previously held ideas, we believe that this is the way forward. Sorry, someone was trying to take a picture. Within the cultural humility tool, within the tool, we offer 3 components. One is a background and orientation to cultural humility and the concepts associated with it. Another section is based on sets of skills. Here's an example of a health literacy skill called Teach Back, and it shows you in a diagram how the tool works and how you might employ it. We have printable PDF downloadable documents that illustrate and are tools that are in the same format. This is an example of Learn, which is a listen, explain, acknowledge, recommend, negotiate acronym to help guide an interaction between a provider and a patient. And then finally, the heart of the tool is this set of 4 case studies, each of which is modeled on the basis of an actual interaction. We worked closely with a group of experienced newcomers and experts in immigration, diversity, and cultural humility who developing these case studies, and each of them is intended to illustrate the experience of the healthcare provider as they engage with and reflect upon the interaction they're having with the person in front of them. Because this funding came from Population Public Health at PHSA, the focus in these first 4 case studies are on mental health challenges. Our hope is that with additional resources, we'll be able to grow them beyond the issues of mental health. But as you know, there is no health without mental health, and given the challenges for migrants and newcomers, it's particularly valuable and hopefully useful. We're currently in the process of evaluating culturallyconnected.ca, and we look forward to inviting any of you who are interested in participating in that evaluation. I look forward to discussing questions you might have about this tool or any others in the discussion period. Thank you.